Hello, and welcome to our uh, Unit 4 presentation. This one in particular is pretty content heavy, and we are aware of that. Um, we are hoping that by doing this lecture, we are shining a light on some of the topics that students tend to find most difficult or may kind of skip over in the readings. This lecture is by no means a comprehensive overview of the unit itself. There are actually other medications that I don't cover here, but I think you've had probably enough exposure to that it's not necessary, and or the number of questions on the exam is so low that maybe we'll can take our chances with that content and cover the ones that are more likely to be asked. So let's continue on to the first topic, which is antihypertensives. First and foremost with antihypertensives is the fact that patient education should always include slow position changes and lying down if hypotension occurs after the patient has taken their antihypertensive. Also, we may even suggest that they take it at night so that they can go to bed and kind of sleep through the times when an orthostatic hypotension might occur. So ACE inhibitors are the first antihypertensive that we discuss, and they do a couple different things. They reduce levels of angiotensin II, and they increase levels of bradykinin. So ACE inhibitors, as a result, dilate blood vessels, reduce blood volume, and prevent or reverse pathologic changes in heart and blood vessels. Some of the side effects of ACE inhibitors are hyperkalemia, fetal injury, cough, and angioedema. And actually, the cough is the most common side effect and reason for switching medications, actually, because 10% of patients taking ACE inhibitors complain of a mild to severe dry cough. And a lot of times it doesn't go away and it requires the medication to be stopped and changed, but sometimes it does go away. So usually the patients will be requested to try to take it for a while and see what happens. ACEs are contraindicated in pregnancy because of the teratogenicity. They are harmful to developing fetuses. They actually have been known to cause major congenital malformations such as hypotension, skull hypoplasia, pulmonary hypoplasia, renal failure, and death. So we do not give ACE inhibitors to pregnant women. Okay, beta blockers, also called beta adrenergic antagonist. If you see beta adrenergic antagonist on the exam, just know beta blocker. That's what it does. It antagonizes or blocks those beta receptors. So tiny proteins called beta receptors sit on the outer surface of many cells, and so there are three main types. The beta-1 receptors are found almost exclusively in heart cells. Beta-2s are in the lung and blood vessel cells, although heart cells do have some. And beta-3 receptors are located in fat cells, or on the surface of fat cells, I should say. The job of beta receptors is to latch onto those chemical messengers released by the nervous system. In response to these messengers, the heart beats faster, blood vessels constrict, the airways relax, and the kidneys increase production of a protein that boosts blood pressure. Beta blockers subvert these processes by settling onto those beta receptors and preventing the chemical messengers from binding to their receptors. So this is how they block those receptors. And this in turn slows heart rate, improves the conduction of electrical signals in the heart, relaxes blood vessels, and then lowers blood pressure. Okay, so there are three different types of beta blockers. First, we have the non-selective, and these were the earliest beta blockers that were made. Propranolol is an example, and they affect both beta 1 and beta 2 receptors. And because of this non-selective effect, these types of beta blockers should be used with caution, if at all, in smokers or people with asthma and other chronic lung conditions. It can actually cause the airways to constrict even more. The cardioselective were a later type of beta blocker that were created, and these include atenolol, metoprolol. They were designed only as the beta 1 receptor blockers in heart cells. So they don't affect the beta 2 receptors in blood vessels and lungs. And so the cardioselective beta blockers are actually safer for people with lung disorders. And then we have the third generation. Some beta blockers do more than block beta receptors. So labetalol actually blocks alpha receptors too, and so this further helps relax blood vessels. I know we always give labetalol as kind of a PRN potent antihypertensive in the ICU. Nebivolol stimulates the inner lining of blood vessels to generate nitric oxide, which helps the vessels relax, and carvedilol actually does both. Okay, switching gears to calcium channel blockers, but one thing I want to point out is calcium channel blockers and beta blockers have two things in common. They both can lower heart rate and lower blood pressure. So anytime you have a patient on both, you would need to definitely monitor heart rate and blood pressure. So there are two different types of calcium channel blockers, the dihydropyridines and the non-dihydropyridines. So the first group, dihydropyridines, include the nifedipine, isradipine, felodipine, nicardipine. I'm not going to name all of those, but they're very potent vasodilators, and they have little or no negative effect clinically upon cardiac contractility or conduction. So they're actually typically used to treat hypertension and chronic stable angina. So different agents and preparations have different durations and action, but the longer acting agents are generally safer and are increasingly preferred by providers. These agents are preferred over the non-dihydropyridines for the treatment of hypertension. The non-dihydropyridines are more cardiac impactful. These are like verapamil and diltiazem. They are used in the management of hypertension, but also typically for cardiac arrhythmias, especially the tachyarrhythmias. They're somewhat less potent vasodilators, and so and have greater depressive effect on cardiac conduction and contractility. And then we have our statins. And really the biggest takeaway from this slide is you know what statins do. Primarily they are to lower LDL cholesterol, but one of the important patient education points you always need to make to patients who are starting a statin or are just taking it is that muscle pain can be a sign of myopathy and rhabdomyolysis. And even though that's rare, I've actually seen it happen. These patients can come in with kidney failure and death. And so any patient with new onset of muscle pain while taking a statin drug should definitely undergo careful evaluation. Okay, and then we switch gears to diabetes. So for patients who are insulin dependent, and those can be type 1 primarily, but also type 2, here are the insulins, the different preparations that there are. I'm sure we're all familiar with Lispro, Humalog, some of those really short-acting ones that we give to patients, especially in the hospital prior to meals and at bedtime. These have a very short duration, very fast acting, and very fast time of onset. And then we move into the regular insulin, which we generally only give now for like as an IV form for diabetic ketoacidosis. We may give it there may be a few other indications, but honestly not many. And then the other one that we use mostly is the long-acting, long-duration, 18 to 24-hour Lantus levemir. And then there's an even ultra-long duration called Tresiba. And these are taken either every 24 hours or even longer. And they help to really regulate blood glucose over a longer period of time. So I don't know if you want to take a screenshot of this PowerPoint page or not, but it would be good maybe to refer to later. The goal in type 1 diabetes is to maintain glycemic control. And a lot of times how we do that is we encourage patients to count carbohydrates. Eating any food that they desire is going to lead to hyperglycemia. So they really do need to monitor their intake. However, eating only protein to promote fat breakdown, as well as restricting calories, can lead to ketosis and potential ketoacidosis. So we want to protect our type 1s from that. You know, the new keto diet that's popular right now is probably not a good idea for them. And then self-monitoring in the patient's own reporting is notoriously unreliable, very subject to error in the reporting of diabetes control. And so what we do to get a more comprehensive look at kind of what the average of their blood glucose has been is to look at their glycosylated hemoglobin, also called a hemoglobin A1C. It's a very reliable assessment of the average blood glucose over the past 3 months. You know, a fasting blood glucose is just a snapshot in time, and that is not as helpful to us, although we do draw those for some reasons. Hyperglycemia, hypoglycemia, and ketoacidosis are short-term complications of diabetes, while peripheral neuropathy, arterial insufficiency, carotid stenosis, and kidney failure are long-term complications of diabetes. I added kidney failure in there. I don't know why it's not there now, but it definitely needs to be there. Okay, here we have the non-insulin drugs for type 2 diabetes mellitus. This is another one where you might want to take a screenshot and look at it later. Get familiar with what the mechanism of action is, because if you know what the mechanism of action is, you can start to predict what the possible side effects might be. So take a look at that, and it's also something you will want to refer to later as you're studying. Diseases of the thyroid. So we start with hypothyroidism, and this often is characterized by decreased heart rate and temperature, falling out, brittle hair, cool and dry skin, pale, puffy, expressionless face. Patients often complain of lethargy, fatigue, cold intolerance. In particularly bad cases, mentation may even be impaired. And then the thyroid may also be enlarged as well. So in iodine-sufficient countries, the principal cause is chronic autoimmune thyroiditis, also called Hashimoto thyroiditis. Other causes are insufficient iodine in the diet, surgical removal of the thyroid, and destruction of the thyroid by radioactive iodine. Adult hypothyroidism may also result from insufficient secretion of TSH and TRH. And of note here, maternal hypothyroidism during pregnancy can result in neuropsychological deficits in the child and must be treated with thyroid hormone replacement therapy. Standard replacement regimen consists of levothyroxine or T4 alone, not necessary to also give T3 as it converts to T4. An important education piece when starting a patient on levothyroxine, also called Synthroid, is that they need to take it on an empty stomach about an hour before a meal so that absorption is increased. Okay, hypothyroidism in infants. This is a little different. Causes can be failure in thyroid development, autoimmune disease, severe iodine deficiency, TSH deficiency, and exposure to radioactive iodine in utero. And so these newborns require replacement therapy with thyroid hormones. And if treatment is initiated a few days after birth, physical and mental development will be normal. However, if it's delayed beyond 3 to 4 weeks, there's probably going to be some permanent disability, although the physical effects may reverse and most likely will reverse. In all children, replacement therapy should continue for 3 years, after which it should be stopped for 4 weeks. And the objective is to determine whether thyroid deficiency is permanent or transient. And if TSH rises, this indicates that thyroid hormone production is low, and we know the deficiency is permanent, so replacement therapy should resume. However, if TSH and T4 normalize, we know the deficiency was transient, and further replacement therapy is unnecessary. In infants and children, hypothyroid characteristics include delay in mental development and changes in growth patterns, large protruding tongue, potbelly, dwarfish stature, and impaired development of the nervous system, bones, teeth, and muscles. And then we have hyperthyroidism, often characterized by the tachyarrhythmias, anxiety, insomnia, rapid thought flow or speech, increased temperature, and weight loss. If a patient presents with a complaint of anxiety or they demonstrate pressured speech, a lot of times I think providers tend to start thinking it might be anxiety or maybe a bipolar mania, but any of these situations really do indicate the need to draw a thyroid panel because it could be hyperthyroidism. There are a couple different causes: Graves' disease and toxic nodular goiter, also called Plummer disease. Graves' disease is the most common cause of the excessive thyroid hormone secretion. It occurs mostly in women 20 to 40 years of age. And toxic nodular goiter is the result of a thyroid adenoma, so a tumor. And they have the same symptoms as Graves' disease except for absence of exophthalmos. The treatment for hyperthyroidism is actually directed at decreasing the production of thyroid hormones. And so 3 modalities can be employed. 1 is surgical removal of thyroid tissue. 2 is the destruction of thyroid tissue with radioactive iodine. And 3 is suppression of thyroid hormone synthesis with an antithyroid drug called methimazole or propylthiouracil. Radiation is actually the preferred treatment for adults, whereas antithyroid drugs are preferred for younger patients. Beta blockers and non-radioactive iodine may be used as adjunctive therapy. Beta blockers are helpful to suppress tachycardia, can also suppress some of the anxiety brought on by hyperthyroidism. Non-radioactive iodine inhibits synthesis and release of thyroid hormones. Because exophthalmos is not the result of hyperthyroidism per se, this condition is not improved by lowering thyroid hormone production. And if it's severe, it can be treated with surgery or with high doses of oral glucocorticoids. Also, we need to teach patients about the need for covering their eyes while they're sleeping if their eyelids don't completely cover the cornea, because it can result in abrasions and injury to the eye. They need to keep their eyeball moist. Okay, antihistamines. Effects of histamine 1 stimulation. Histamines aren't all bad. They do cause vasodilation, increase capillary permeability, especially in the inflammatory and healing process, bronchoconstriction, CNS and PNS effects, such as help with memory, sleep-wake cycle, seizure suppression, regulation of energy. But they also cause itching, pain, and secretion of mucus. So this is where histamines bug us really a lot sometimes, especially during change of season. So the effects of histamine 2 stimulation are secretion of gastric fluids, probably should say there. Role of histamine in allergic responses is allergic reactions are actually mediated by histamine and other compounds. So the intensity of an allergic reaction is determined by which mediator is involved. The symptoms of mild allergy, such as rhinitis, itching, localized edema, are caused largely by histamine acting at H1 receptors. As a result, mild allergic reactions, hay fever, urticaria, mild transfusion reactions, are generally responsive to antihistamine therapy. There are 2 types of antihistamines. We have histamine 1 antagonist and histamine 2 antagonist. H1 blockers treat mild allergic disorders. H2 blockers treat gastric and duodenal ulcers. Because H2 antagonists do not block H1 receptors, these drugs are of minimal use for treating allergies, although they are sometimes used. Therefore, we do focus primarily, though, here on H1 antagonists. Mechanism of action is the H1 blockers bind selectively to H1 histaminic receptors, thereby blocking the actions of histamine at these sites. Adverse effects of first-generation antihistamines are highly sedative, dry mouth, urinary hesitancy, and constipation. First-generation antihistamines are very effective, though, in blocking histamine. We know the one really popular one is Benadryl. We've also probably seen hydroxyzine used, promethazine, but they also cause the dry mouth, a lot of the urinary hesitancy too, and that can be especially bad in older people. So we do have second generation antihistamines, and they are non-sedative and have more minimal anticholinergic effects, although sometimes patients complain that they aren't as helpful as an antihistamine or a histamine blocker. Okay, the last 2 slides have to do with asthma, and I'm not going to say a lot about them because I do want you to maybe take a screenshot or look this up in the text, but I do want you to know that you probably should be aware of the stepwise approach for managing asthma in children 12 years of age or older and adults. And this is kind of a step-up type situation. And then the next slide is one that shows what each medication falls into, which classification, I should say. So you might also want to take a screenshot of this. Pay particular attention to this information in your textbook as well. Asthma and COPD are a big problem in the United States, really worldwide. especially for countries that have the high smoking population. And so we do want you to be aware of how we treat them. There's so many different types of inhalers, and using the stepwise approach is how we decide which inhaler to use. So do become familiar with this. Again, this lecture is not an exhaustive look at all of this. It really isn't. You need to take the knowledge check questions at the end of each section in the unit, and then the quiz questions and the little quiz at the end to really make sure that you understand this content. Thank you.